Thank you very much. That's a great pronunciation. So my name is Sudeep. I'm a fellow here at the Texas Heart Institute. We'll go ahead and get started. So we had a patient. She was 72 years old, female, no prior cardiac problems. She did have a history of diffuse large B-cell lymphoma. She presented with fever and abdominal pain. She was actually found to have an infected fistula between segments of her small bowel, and she was empirically starting antibiotics. By hospital day 5, however, she developed acute pulmonary edema, hypotension, shock liver, acute renal failure, and new AFib. She had to be intubated, and she was quickly on 3 pressors. At the time of the event, her troponin was 1.1, and this is her EKG, probably most notable for diffuse precordial T-wave inversions. And then this is her echocardiogram, her apical 2-chamber view, and as you can see, the contractility is down. Her LVF was estimated at 15-20%, but that's probably an overestimation. And more specifically, you can see she had these segmental wall motion abnormalities in the apex and mid segments, with the basal segments appearing to contract normally. This is her parasternal long axis, and you can see the RV a little bit better with some mild dysfunction and some mild dilation as well, but certainly not as bad as the LV was. So given the kind of constellation of these wall motion abnormalities, the troponin elevation, and the EKG changes, we wanted to rule out any obstructive CAD. We took her to the cath lab. Her left heart cath, and her left side here was clean, and her right side, again, as you can see, showed no obstructive CAD as well. We kept her in the cath lab, replaced a Swan-Ganz catheter, and as you can see, her filling pressures were significantly elevated. Her right atrial pressure was 21, your wedge of 16. Her cardiac index was depressed as well at 1.76, SVO2 28%, and her PAPI was 0.52. So at this point, Takotsubo was probably the most likely diagnosis. We won't know that for sure, but I think kind of based on all the evidence so far, that's what we came to. The biventricular variant is not as common, obviously, but it is more associated with cardiogenic shock. So just what that noise is. So at this point, to summarize the case so far, we have a patient here who had no prior cardiac problems. Came to us 5 days into her visit and basically presented with acute cardiogenic shock. And she at least had LV failure, probably BiV failure at this point, with elevated filling pressures, and she was on 3 pressors. So we kept her in the cath lab, again, the left heart cath, right heart cath done at the same time, kept her in the cath lab and placed an Impella CP. And this is really the turning point of this case, and I think the main reason why I want to present this case is, after placement of the Impella CP, we decided to keep the patient in the cath lab for about 20 minutes because we did suspect some RV dysfunction. And after placement of the Impella CP, you can see that her filling pressures remained elevated, and her index improved only a little bit. Her SVO2 went up to 33%, and her PAPI dropped significantly to 0.27. So we kept, again, this is kind of in the same visit. We kept her in the cath lab, and about 30 minutes after placement of the Impella CP, we placed a 29 French Protec duocannula device that was attached to a tandem heart pump. And as you can see, you might be able to see the inflow cannula is the right atrium, the outflow cannula is the main PA. And what we did basically, we had the PAC in, we placed a very stiff wire through the PAC, removed the PAC, and then placed this 29 French cannula device and attached it to a tandem heart pump. And this is a good image of both pumps working together in tandem. So unfortunately, we did not immediately replace the PAC, but these are her numbers within a few hours after placement of both devices, and you can see that her right atrial pressure improved tremendously, and her SVO2 also improved to 79%. So it gave us some evidence that we were able to unload the LV while also reducing her filling pressures. And indeed, her status improved in subsequent days. The tandem was explanted on the 4th day, with the CP explanted on the 8th day. She was extubated after the removal of the of the right-sided tandem heart. Her renal function returned to normal, and this is her echo post at discharge. As you can see, she has normal function now. Her LVEF was 55%, and the right side was doing great as well. So I think the biggest take-home message here is actually twofold. Number one, we can never ignore the right ventricle, right? So, we do all this work in placing the Swan-Ganz catheter, and then it only takes a few extra steps, a few extra seconds to really figure out what the RV is doing. And we like to use the PAPI, but there are other indices as well. Obviously, like the RV stroke work index. You compare the right versus left side filling pressures. And you can really try to get a good, as someone mentioned in the last couple of days, a good profile of the RV, not just looking at the echocardiogram and not just looking at the filling pressures, but really try to understand what the RV is doing. And the second kind of take-home point that's related to this is that if you do suspect RV dysfunction, based on the information you have, and you place a left-sided device, it may be worth it to keep the patient in the cath lab for an additional few minutes to see how the RV responds. I think it would be really easy to send the patient back to the CCU and ask the critical care team to follow up on how the RV was doing, and kind of waste a few hours there, and by that point the prognosis may have been worse for the patient. So I think that's probably the biggest take-home point here is. And then, of course, acute biventricular support is feasible and ideal in certain cases of cardiogenic shock. Really believe that PAC is a necessary component of the management of cardiogenic shock, as displayed in this case. I think here you can see that there's some discrepancy between how the RV was doing versus the LV. As I mentioned earlier, the echo potentially showed the RV was not functioning as poorly as LV, but you can see it was just as bad. And then finally, I'll kind of leave off with this slide. I'm not going to go through it, but our institution has kind of created this algorithm over the last several months, kind of like a shock algorithm. Again, this is not meant to be a hard and fast thing where we kind of follow the rules, kind of go down the protocol here, but it's really meant to serve as a template for discussion in the future and really try to, essentially help us manage these cases better in the future. Thank you for your time. I'll take any questions.
That's really an excellent case. I just want to make really quickly 2 comments and ask you. So when we did the neurocardiogenic stunning series at Hopkins, I was a fellow. I was running around getting samples for Dr. Wittstein, who published the first, along with Dr. Marin, case report. We biopsied a lot of these patients, by the way, and had right heart caths, and you're right on. The right side showed its ugly face. Now, what did we use back then? Impella I trained in the era pre-Impella. We used balloon pumps, which didn't stress the right heart with left-sided support. So my question for you is, you did great with the case. Was there? First of all, you should write up this case because I haven't seen a Takotsubo case with left-sided Impella failing. That's important. But did you? How quickly did you go to the tandem? To the Protect Duo. And what did you flow the Protect Duo at? That's the second question, because the CP can't give you more than 3.5, 3.8 liters.
Yeah, so that's a great question. So as I mentioned, we were able to place the tandem within about 20 minutes after the placement of the CP. We kept the patient in the cath lab on the table and waited to see how the RV would respond. And the second question, sorry, I forgot what the second question was.
What did you flow that?
Oh, it was at 2.5 liters.
I have a question that if you, in the beginning, in a couple of days you said that you were able to win the tandem heart, so it's a temporary RV failure. How about if you, in the startup, if you went for a stronger pump and then aggressive CVVHD and avoiding do you think you would be able to avoid the RV support?
Yeah, I think that's possible. We basically took the patient to the cath lab a day later, and I think would have been possible. Her kidneys weren't doing so poorly where she needed CVVHD at that point. She was still making some urine and a reasonable amount. Was that kind of your question?
But my point is that it's not just you making some urine is aggressive CVHD and pulling out volume
Right,
with a
right.
stronger pump.
I see what you're saying.
I think that it would be able to avoid the RV right pump.
Yeah, I think that would have been a reasonable alternative.
So Sudeep, excellent case. I think for me personally, what I found very interesting in this was the biventricular involvement with Takotsubo, which is usually more of, there's multiple variants as we have always seen. This seemed more like the apical variant. Usually you have much more deep inverted T waves than the ones that we saw in the EKG. Again, that's not always classical. Did you have an LV gram in this case? Because that usually clinches the diagnosis. Obviously, it sounds like on echo it was fairly clear. What's helpful to me a lot of times in LV gram, especially in the cath lab in somebody who's hypotensive and you don't have all the data up front at that time, is sometimes in Takotsubo, with especially a very hypercontractile basal segment, you can have tethering and changing coaptation plane of the mitral valve, and you can have severe acute MR, which is very under-recognized with Takotsubo. And so the management obviously changes based on that, and maybe that may be another factor that made the right side look worse. So I just wanted to see if you guys have an LV gram and if that showed any MR. And the second thing I was interested in is it's very rare for us to see, anytime you unload the left side, we always worry about the right ventricle failing. So what I found interesting in your case is the PAPI obviously was low to begin with at 0.53, but then after Impella placement, the PAPI came down to 0.28. So that is an important point to do that calculation in the cath lab and not walk away because you'll be back very soon in a much worse situation. So I think that was a good thing that you guys did.
Right, absolutely. And with regards to the first question, we did the LV gram, there was no MR. And it did show something similar to the echo, actually. It was a very hypokinetic apex and mid segments. And with regards to the BiV, the BiV variant, it's interesting. I've read in papers that the incidence is only 0.5%, but I think that's pretty low to what we actually see. I think we do see much higher degree of the BiV variant.
So one final comment is the fact that the patient had diffuse large cell lymphoma that obviously wasn't under control, and her age. Sometimes we wonder. Certainly, you did a great job supporting her, but what if she didn't get better? What if what if it wasn't Takotsubo? So sometimes we might have a little bit of pause about supporting this patient based on her history of carcinoma. I wonder whether some of this actually might have been chemotherapy related.
Yeah, that's a great question. her, again, she came in with no prior cardiac problems that we knew of, absolutely. And kind of based on the wall segment and the wall motion abnormalities and where it was, I thought that was the most reasonable diagnosis. It wasn't really diffuse cardiomyopathy or dilated cardiomyopathy. It's more kind of, with regards to specific segments. So at that point, we thought it was a reasonable diagnosis, kind of given everything that had been going on the previous 5 days. And the lymphoma had kind of been in the past like several years. But yes, I think that's a great point about the chemotherapy that can kind of occur at any point after the therapy.
It's a very short comment regarding central venous pressure and wedge. You went to the cath lab with CVP higher than the wedge. I think that's an important point for us moving forward to say patient selection and device selection. It's a BiVAD case. Nobody's going to send patient for chronic LVAD with a CVP higher than the LA. That's something here we have to, moving forward, to say the concept for me now is patient need a BiVAD support. We can discuss which BiVAD we can put in the patient.
Thank you so much.
Thank you.
Can we get one more question? Just one more question? Go ahead.
Yeah, I think a quick comment and a question for the panel. I think what you showed is a protect Pella. And we're seeing more and more of this because either if the CP is not enough and your septal shift makes the RV worse, and I'm not sure if RP is always successful, and we've not had great success with RP in these situations. In an acute MI setting, I think it's perfect. It does pose challenges of dual pumps and two different pumps. My question, and maybe the panel can comment, is we've talked a lot about PAPI, but PAPI has not been validated in these settings. So it's very careful to make sure that if your RA pressure is very high because somebody's wedge is 40 and RA is 28, your PAPI will look low. But what you pointed out is it's a combination of echo, hemodynamics, and PAPI. So I don't know if the panel has thoughts on if we should just put our money on PAPI or not.
I think that's an excellent point. I think Ali's comment about the CVP to wedge ratio gives you a, continuous physiologic assessment of how the RV is filling the LV. But then there's a biology of neurocardiogenic stunning, if this is what it is, to Dave's point. I think that's a great comment he made. PAPI isn't everything. If you live by PAPI, you better be ready to not live by PAPI. But anyway.
And last thing I'd say is I teach my fellows that the mixed venous is everything. And so absent holes in the heart or other funny connections, like in your case where you saw the mixed venous still was horrible after left-sided support. So that really nails it that you needed the right-sided support.
Absolutely. Thank you.
Thank you so much. We'll go on.